Hi everyone, welcome back. In this short recording, we're just going to be learning about individual responses to drugs. And we've only got one learning objective for this part. Now, pharmacogenetics is the study of how genetic variability affects the response to drugs. And the frequency of polymorphisms between different ethnic groups and between different races also sort of contributes to difficulties in individualizing drug therapy. So our inherited genes can alter drug response. For example, can alter pharmacodynamics, so the effect that the drug has on the body. For example, alter the available concentration of the target molecule. If you think about it, our genetic DNA codes for proteins. And remember, we mentioned earlier on that drug targets are proteins. So if you have a situation where your genetics, say, codes for too few protein receptors, that's going to reduce the efficacy of the drug and therefore alter the response of that individual to that drug. Our genetics also can alter pharmacokinetics, so the way that the body processes drugs. For example, enzymes control drug metabolism. And even though, metabolism can occur in different parts of the body, when we are talking about drug metabolism, we're really referring to what's going on in the liver via those hepatic enzymes. And each enzyme is a protein encoded by a specific gene. Now, previously, in the previous recording, I mentioned how, liver enzymes can be used to activate prodrugs from the inactive form to the active form. But liver enzymes are also involved in inactivating drugs to inactive metabolites. And one of the processes of metabolism is acetylation. And what do I mean by acetylation? An acetyl group is added to the drug molecule. All right. And the addition of this acetyl group makes the drug metabolite inactive, and it also makes it more water soluble and therefore more prone for excretion permanently from the body. Now, basically on a population level, 50% of us are what's known as rapid acetylators, and the other 50% are slow acetylators. What does this mean? If you're a rapid acetylator, it means that the body is going to get rid of that drug more quickly than intended. So it's not going to have a very long duration of action, because that acetylation is going to happen quickly, followed by excretion from the body. So that a rapid acetylator for that drug, it will have a shorter half-life and less of an effect on than intended. On the flip side, if you are a slow acetylator, it means that the drug molecules are going to have a prolonged effect in the body, so longer than what they were intended. So that half-life of that drug will be longer. And generally speaking, the longer drug molecules are present in the body, the greater the risk of unwanted effects, many of which can be toxic effects. As well as genetics, though, a person's environment and also stage of life can also alter drug responses. And here you should be thinking about newborn babies at one end of the life spectrum and then elderly people at the other end. Let's take just age in general can affect renal excretion and drug metabolism, and so can alter the type of response seen. If we take newborns, firstly, when a baby is born, their stomach is not making hydrochloric acid. So if you administer a drug that's absorbed in the stomach and there's no hydrochloric acid there, that might have an effect on that absorption of that drug from across the cells lining the stomach. In addition, the liver is also immature in newborns. And finally, newborns are very prone to dehydration, and this also makes it very difficult to get doses of drugs correct. In terms of elderly people, there is usually a level of renal and liver impairment, And this, of course, then can affect excretion of drugs and also drug metabolism. So in this case, when there is, reduced functioning in the kidneys or in the liver, you'd need to be giving smaller doses of drugs to older people. And remember as well that many elderly people, weigh the same as a small child. So doses of drugs need to be per body weight rather than, per age. Also, in elderly people, there can be an alteration in the type of response seen. For example, hypotensive drugs that are used to treat hypertension or abnormally high blood pressure can cause postural hypertension more in elderly people than young people. Okay, so what are we talking about here? As we age, our arteries tend to get harder, a condition known as arteriosclerosis. And this can lead to, blood pooling in lower regions, so in the ankles. So when elderly people then are on these hypotensive drugs might be lying down and they move to standing position, that causes the blood to pool. And of course, that can lead to things like dizziness and fainting. Nutrition is also a big one. The example we've given you here is dietary vitamin K levels and warfarin. I'm not going to go into the mechanism of action of warfarin at this stage, just to know that it involves vitamin K, right? Warfarin is an anticoagulant, so it's given to prevent blood clots, okay? And it is a vitamin K antagonist. That's all you need to know for now. So if you have too much vitamin K in your diet and in your body, and a certain dose of warfarin is not going to work well enough, and therefore that person will be at risk of clotting. Okay. However, if you have too little vitamin K in the body, then that same dose of warfarin is going to work too well, and that person will be at risk of bruising and bleeding. And of course, the use of other drugs, so polypharmacy, it's very well timed here because I'm going to be talking about drug interactions in the next recording. So the use of or having, polypharmacy issues where there are drug-drug interactions and adverse drug reactions will also alter that individual response to a particular drug. Unpredictable responses, including allergic reactions, can occur to some medications also. I'm sure that you've heard that some people are allergic to an antibiotic called penicillin. An allergic reaction is an immune reaction following sensitization to the particular allergen, and in this case it's penicillin. And then on subsequent sort of exposures to penicillin, that allergic or immune reaction becomes greater and greater the more times the person is exposed to the penicillin, and this can then unfortunately lead to a condition called anaphylaxis. And if you remember what anaphylaxis involves, it involves systemic vasodilation, so dilation of systemic blood vessels, leading to a severe drop in blood pressure. And if blood pressure drops too much, this can lead to shock. And if there isn't intervention, it's a very serious condition and it can be fatal. There is a genetic predisposition to these allergic reactions, but they're very difficult to predict. And finally, then, we do have what's known as an idiosyncratic reaction, which is a reaction that occurs for unknown reasons. They are definitely abnormal reactions and they are usually harmful. Thankfully, they do only occur in a small proportion of individuals. Okay, everybody, very nice, short and sweet. When I come back, I'm going to be talking about drug interactions.